All right, I think we'll get fired up here. 7:30. Hope everybody finished their questions. For those of you that I haven't met in person yet, I'm Joe Sullivan. I'm a PGY1 general surgery resident, and I'm presenting today on adrenal, pituitary, and endocrine. So overview. So the score, the year 2 topics for score, I think they're actually the same year 1 and year 2 for adrenal, pituitary, endocrine, adrenal mass, incidentalloma, hyperaldosteronism, hypercortisolism, pheochromocytoma, and adrenal cancer. Overview of what we're going to talk about. First, going to describe anatomy, physiology of the adrenal glands. Then we're going to go into the workup for incidentalloma and non-functional adrenal lesions. Then we'll move on to functional adrenal tumors and finally malignant adrenal tumors. So first with some anatomy, the adrenal gland has a segmental blood supply. The superior adrenal artery the aorta. Inferior adrenal artery is via the renal artery. Importantly as well, the adrenal veins also go to different structures. The left adrenal vein goes to the left renal vein. The right adrenal vein goes directly to the IVC. And the lymphatics drain to subdiaphragmatic and renal lymph nodes. In terms of physiology of the adrenal gland, as we saw in some of the questions, this was definitely fair game for board exams. So we're looking at a transverse section here. You can see the cortex and medulla of the adrenal gland. The mnemonic to remember the different zones of the adrenal gland and going from outer to inner, you can remember GFR. So starting with zona glomerulosa, followed by zona fasciculata, and then zona reticularis, and then the medulla is the deepest. To remember what is produced by each zone, you can remember salt, sugar, sex. The deeper you go, the sweeter it gets is the mnemonic everybody remembers. So that's to say that zona glomerulosa produces mineralocorticoids, like aldosterone. Fasciculata does glucocorticoids, reticularis androgens, and the medulla does the catecholamines, epinephrine and norepinephrine. I'll continue with some physiology for aldosterone secretion. So the kidneys produce renin in response to decreased blood pressure, which will cleave angiotensinogen into angiotensin 1, which via ACE in the lungs will become angiotensin 2. And this will go, what we're mostly worried about today, is this will go to the adrenal cortex and stimulate the production of aldosterone. And as we know, it also does multiple other things, which we'll talk about a little later. In terms of cortisol secretion, the hypothalamus produces CRH, which stimulates the anterior pituitary to release ACTH, which acts on the adrenal cortex to produce cortisol. This subsequently has a negative feedback loop. Some of the things downstream that cortisol does, it's involved in gluconeogenesis, protein mobilization, fat mobilization, and the stabilization of lysosomes. So we all remember as well, cortisol secretion over 24 hours has varying levels. It's highest in the morning and then wanes down as we go throughout the evening. That's why it's important to remember when we're looking at cortisol levels, if you look at it just the plasma cortisol level, it's kind of just a screenshot. That may not be indicative of the overall profile of somebody's cortisol production. Continuing with some physiology in terms of congenital adrenal hyperplasia. I won't go into the whole pathway here from cholesterol conversion, But the key ones to remember for congenital adrenal hyperplasia is these three deficiencies. So 21 hydroxylase deficiency, you're going to get an increase in 17 hydroxyprogesterone. So this is going to lead to increased testosterone, precocious puberty, and a lack of aldosterone production, leading to salt wasting. The 11 beta hydroxylase deficiency, which is going to lead to an increase in 11 deoxycortisone, which also acts as a mineralocorticoid. So you're going to have hypertension, and then 17 alpha hydroxylase, which will lead to virilization, hypertension. For the adrenal medulla, chromatin cells are going to be the active cells here. We're going to get the conversion of phenylalanine to norepinephrine, and then via PMNT will be converted to epinephrine. The rate limiting step in this pathway is tyrosine oxidase. And importantly to remember as well, PMNT, which is the enzyme that converts norepinephrine to epinephrine, is only found in the adrenal medulla, as well as the organ of Zucker-Kandel, which can be found either in the aortic bifurcation or the IMA origin. Now we'll start to get into the workup for incidentalomas. So this is the most common adrenal lesion that surgeons are going to be asked to evaluate. As the name implies, they are found incidentally on imaging. It's made to be seen in 1 to 5% of CTs for other reasons. Three important questions you want to ask yourself when presented with an incidentaloma is obviously one, is it definitely in the adrenal gland based on the imaging? Is it functional tissue? And is it potentially malignant tissue? So in terms of the composition of incidentalomas, the vast majority are non-functioning adenomas, which we'll talk about in a little bit. Next largest slice is pheochromocytoma, which makes up 10%. And then continuing down with a couple other things that we will talk about as we go throughout the presentation. So starting with the most common incidentaloma, a non-functioning adrenal lesions. So a non-functioning cortical adenoma is the most common lesion to be seen as an incidentaloma, 60%. They are benign and non-functioning. Most are smaller than 4 centimeters, which is an important number, as we saw in one of the questions. That's kind of your cutoff point to really be safe to think that it's a non-functioning incidentaloma. If it's larger atypical imaging, you may consider an adrenalectomy, as we'll talk about. The phenotype you'll see on CT will be smooth, homogeneous, round, with sharp demarcations, usually unilateral and less than 4 centimeters in diameter. And you'll also see low attenuation on CT, less than 10 Hounsfield units. Ominous characteristics that you may see in the workup for a non-functioning cortical adenoma, kind of just the opposite of what we just talked about. If it's non-homogeneous, if it's greater than 4 to 6 centimeters, if you have repeat imaging and it shows that it's enlarging, or over time it converts from non-functional to functional, those would all be kind of concerning characteristics. Overall, though, if you have no concerning characteristics, you can manage these by serial imaging and follow-up in at least 6 to 12 months. And depending on the situation and characteristics you may see, you may consider resection, depending on the clinical scenario, the patient age, or the imaging phenotype. Other non-functioning adrenal lesions include myolipomas. These are also benign adrenal lesions made up of fat and bone marrow elements. They can get quite large, up to 10 to 15 centimeters, and can be bilateral. They're recognizable by the presence of macroscopic fat on CT or MRI. These are usually asymptomatic, but if they're very large, could have mass effect, presenting with some symptoms. These should not be removed unless, again, atypical imaging appearances, or you suspect it may be causing local symptoms through mass effect. Some other non-functioning adrenal lesions to know, but that we won't discuss further. Obviously, you could have adrenal hemorrhage and adrenal cysts, ganglioneuroma, and these are typically all going to be differentiated by the imaging characteristics.
Just a quick, good morning, guys. Dr. Fernandez here. Just a quick comment about myelolipomas, because they're not that infrequent, and a lot of the times we, when they start growing, we do surveillance like we do with many of the adrenal masses. But when they get bigger, sometimes they can bleed actually. So depending on the age of the patient, the physical activity that they do, sometimes we remove them. It's not mandatory, but that's another indication, maybe risk for bleeding. Okay, just wanted to put that there.
Thanks, Dr. Fernandez. So moving on to our first review slide, I'm going to pick on my own team. So team 3, who are in the room with me right now. Going to ask them about the adrenal blood supply. So go ahead.
Yeah, so superior adrenal artery via inferior phrenic,
Right.
middle adrenal artery via the aorta, inferior adrenal artery via the renal artery. Left adrenal vein goes into the left renal vein. And then the right adrenal vein goes into the IVC. Sweeter sex inside, so goes from aldosterone, then cortisol, then sex steroids. Oh, the 3 zones you wanted: the glomerulosa, fasciculata, and reticulosa. Yeah, R.
Good.
Like reticularis, sorry. And the most common one is the non-functioning cortical adenoma.
Good.
Well, you can't forget about the layers, right? Think
Right.
about, my initial GFR, so can't forget about it.
All right, continuing on. So this is a slide we're going to come back to a couple times in this presentation, kind of the workup when you see an adrenal incidentaloma, and what you might consider in the differential when you do see one. So we just finished discussing the non-functional adrenal lesions, and we're now going to move on functional tumors of the adrenal gland that you could see with an incidentaloma. It's important to see kind of as well, as we go down this pathway, the different workup. We'll talk about this in detail in each step, and we'll return to this slide later, but I just wanted to put it here as a reference point to start. So the first functional adenoma we'll talk about is cortisol hypersecretion, also known as Cushing's syndrome. So this is going to come in terms of the adrenal gland from a cortisol secreting adrenal mass. Other Cushing's syndrome sources could be a pituitary ACTH hypersecreting adenoma, and this is what you would refer to as a classic Cushing's disease. A primary adrenal tumor, as we are talking about now, which makes up 15% of Cushing's syndrome sources. You could have an ectopic ACTH secretion like from lung cancer. And the most common cause is, importantly to know, iatrogenic steroid use. So kind of the syndrome of Cushing's syndrome, probably all remember this from medical school, the moon facies, buffalo hump, easy bruising, peripheral muscle wasting. They have kind of an abnormal central fat deposition, kind of the abdominal striae, and they could have some psychiatric features as well. So cortisol hypersecretion workup, history and physical is obviously going to be the first step. And as we saw kind of with the Cushing syndrome on the last slide, this is going to be a really important way to identify it right from the jump. Moving on to biochemical testing, the initial screening, which was important in some of the questions that we had seen before the presentation, going to start with a 24-hour urine cortisol. If you have equivocal results, you can then go on to a late evening salivary cortisol. But as we saw as well, remember the differences in cortisol production throughout the day. So that would give you kind of a look into whether or not, if it's elevated later in the day when it should be mostly down, that would be a good sign that you have some hypersecretion. You also want to consider evaluating for ACTH dependency versus independent Cushing's. So when ACTH levels are undetectable, this is pointing to an adrenal source because it's ACTH independent, so it's acting directly from the adrenal gland itself, rather than a pituitary tumor or ectopic ACTH source acting on the adrenal gland and causing the hypersecretion. So when you do have ACTH levels undetectable, 90% of the time this is going to be a solitary adrenal adenoma, but 10% of the time it is a adenocarcinoma. And less than 1% of the time you could have a bilateral micro or macronodular hyperplasia of the adrenal gland causing this hypercortisolism. When you have normal or elevated ACTH, this is going to point towards a pituitary or ectopic ACTH hypersecretion. You're going to want to get pituitary imaging, MRI, and as well as more biochemical testing like a high dose dexamethasone suppression tests. With that high dose suppression test, if you have urine cortisol levels that are suppressed, this would point towards a pituitary adenoma. And if it is not suppressed, this would point to an ectopic source that's not responding to the increased dexamethasone that should be suppressing it, would point towards small cell lung cancer. If the pituitary is suppressed and you have a pituitary mass greater than 6 millimeters, you would consult neurosurgery for a transsphenoid microsurgery. And if there's a failure of cortisol suppression after that pituitary surgery, this may be an indication to further work up and do a bilateral adrenalectomy. Indications for resection for hypercortisol secretion. So Cushing's, if you have unilateral adenoma or adrenal cancer, bilateral adrenalectomy, again, if you have failure of pituitary surgery in ACTH dependent Cushing syndrome, as we just discussed, or if you have an inoperable ectopic ACTH producing primary and want to act at the site of the adrenal glands to prevent the symptoms of the hypercortisolism, even though that you can remove the ACTH producing primary tumor. For subclinical Cushing syndrome, significant comorbidity secondary to elevated cortisol, tumors greater than 3 to 4 centimeters, or enlarging tumors on serial imaging, all may be indications for resection. Perioperative management for this preoperative steroid stress doses. Postoperatively, you want to taper the steroids ranging for weeks to up to a year. Also important to remember that Cushing's disease is a hypercoagulable state, so you want to don't forget about anticoagulation for these patients. Adrenalectomy is usually 90% effective for symptom resolution in Cushing's disease, and that resolution should occur within months. And this is just an overview slide as well of the cortisol hypersecretion workup. So if you identify that patient does have high cortisol levels, again, the first test you want to do is a 24-hour urine cortisol to see the overall production over the 24 hours and not just get that snapshot, which could be down later in the day. Then you would want to determine the ACTH level. If it's low, this would point to an adrenal tumor and an indication for adrenalectomy. And if it was high, with subsequent high dose dexamethasone suppression to follow, would point to either the ectopic ACTH producing mass like lung cancer, or if it is suppressed, pituitary adenoma. So moving on to our second review slide, we have team 4. They want to either log in to talk or could write it in the chat. So they have buffalo hump, easy bruisability, striae, and weight gain. Yep. There's the rest of them, didn't talk about as well. Initial screening if you suspect Cushing's. Great 24-hour urine cortisol. And then if you have an ACTH normal or elevated and the high dose dexamethasone suppression is done.
Joseph,
Yes.
before you move on from the Cushing's kind of, okay, you want to read the answer from team 4?
Yes, they answered correctly. A low result would point towards an adrenal, and a high result would point towards the pituitary source.
Okay, great. So just wanted to comment something, because same thing, you know, you're going to go over other adrenal tumors, and sometimes for the practical aspect of, you know, let's say that a patient comes to the office, you know, obese, stretch marks, diabetes, metabolic syndrome, right? We think about Cushing, and we not always find that the, you know, the let's say the cortisol is significantly elevated. So when we start right now, we start kind of digging a little bit more, okay? And there is something that is in between having a florid Cushing syndrome and having a normal person, and something in between is called MACE. It's something new, and that means mild hypercortisolism. So now those patients may not have everything, you know, the buffalo bump, they may not have the stria, they may not have the obesity, but they come with something. They come maybe with diabetes, hypertension, yeah, they gain weight. So when we study them, we find, for example, that this ACTH may be suppressed, and the cortisol is kind of borderline. And we request, for example, the dexamethasone suppression test by the 1 milligram. And if that comes unsuppressed, because if you give a patient 1 milligram of dexamethasone the night before, the next morning when they go to the lab, the ACTH should be suppressed and the cortisol should be less than 2. That's kind of a measurement that's established. So if it's above that, that means that the patient has some degree of hypercortisolism. Now, what am I saying this is because some patients, some of these patients, they have a nodule and we go to the OR. So it may not be unusual that you see a patient on the table with what we call MACE, which is essentially a mild hypercortisolism. So there is other things in between, you know, it's not just the you know, clear book kind of looking patient with Cushing's. Okay, sometimes the patients that have mild, they still have surgery.
Great, thanks, Dr. Fernandez. Right, so moving on to aldosterone hypersecretion, also known as Conn syndrome. So the hallmark feature of primary hyperaldosteronism is going to be a response to spironolactone, which is a aldosterone inhibitor, versus essential hypertension, which you would not have the same response to. For primary, aldosterone secretion is independent, so renin will be low, and this is going to point you towards an aldosterone adenoma. Secondary hyperaldosteronism, renin production is going to be high, and this is, you would see this in CHF with use of diuretics, liver failure, or Bartter syndrome, which is a renin secreting tumor. And this is just the review of the pathway for the renin angiotensin aldosterone cycle. So aldosterone hypersecretion workup, again, history and physical going to be the first thing you're going to want to do. They're going to have a history of uncontrolled hypertension with having taken 2 to 4 antihypertensive different classes and probably failed. They're going to have hypokalemia a high urine K, and hypernatremia due to the effects of aldosterone on the kidneys. For biochemical testing, get a plasma aldosterone concentration to plasmin renin activity ratio, and one greater than 20 to 30 is going to be pointing you towards aldosterone hypersecretion. This was important in one of the questions we saw before the presentation. Confirmatory testing to follow plasma aldosterone will stay high after salt loading, which you could do orally or IV. For imaging, CT with or without triple phase, MRI, or NP59 scintigraphy, which is a cholesterol analog that's caught by the adrenal cortex LDL receptors, which can help you detect hyperfunctioning lesions. Could also important to remember about adrenal vein sampling. So simultaneous cortisol and aldosterone from left and right adrenal veins and peripheral veins. Aldosterone cortisol ratio greater than 4 times that of the other side would help you lateralize this aldosteronoma. And you can kind of see that in the chart to the right-hand side of the screen, where the right adrenal vein compared to the left, you have the aldosterone ratio of 6.2. So that would help you lateralize to the right adrenal gland for this aldosteronoma. So following up on that, do you want to be selective with who you do adrenal venous sampling for? Some recommend only doing vein sampling in patients who are greater than 40 with unclear laterality on imaging. And then typically when you do an adrenalectomy, you can have 95% cure rates if you had done a venous sampling for aldosterone hypersecretion.
So Joseph, just a quick comment there. So yes, so the cutoff is 4 years old. And even if you have a nodule that is, the aldosterone producing tumors are always very small. They're always like, or I would say most of them, they are like between 1 centimeter and 3 centimeter when they're diagnosed. So even if you have, let's say that you have a 50 years old, history of hypertension, 3-4 medication, all the symptoms and all the chemical, workup done, even if you have a small nodule, we most of the time request AVS because they are a higher risk for hyperplasia. So what does it mean is that you go and remove that that nodule, and the patient will not improve. So in order to avoid that, we are doing the AVS to confirm. And typically it doesn't happen when you are younger than 40. I mean, can happen, but it's less chances of having hyperplasia.
Great, thank you. So continuing with treatment for Conn syndrome, when you have an aldosterone producing adenoma, do adrenalectomy after localization, as we just said. When you have bilateral hyperplasia causing the Conn syndrome, going to want to do medical management with spironolactone, which we said is an aldosterone inhibitor, other antihypertensives to continue to manage the high blood pressure, as well as K supplementation because of the potassium wasting as a result of the aldosterone acting on the kidneys. You can consider bilateral resection if unilateral resection does not control the symptoms or it's refractory to the maximal medical management. If a bilateral resection is done, the patient is going to need mineralocorticoids and steroids for life. Resolution endpoints in terms of perioperative management, control of their blood pressure, hypokalemia, following up with aldosterone concentrations, their antihypertensive requirements, and improvement of especially the blood pressure and hypokalemia could be seen as early as 24 hours. Failure of resolution could be an indication that their symptoms are a component of chronic hypertension, or there could be a microadenoma, as Dr. Fernandez had mentioned. The aldostorones could be quite small, so you could have a microadenoma with hypersecretion of aldosterone on the contralateral side from the adrenalectomy. Just another review slide for hyperaldosteronism. So you're going to want to start with that plasma aldosterone Ren ratio. Greater than 20 would be indicative of primary Conn syndrome from an aldosteronoma. You could follow that up with a salt loading test, and then continue down the pathway that we had discussed. One other functional adenoma to mention as well is sex steroid hypersecretion. Won't take a long time on this, as we kind of discussed it before, but you get viralization and feminizing adenomas from hypersecretion from androgens. This is rare. Less than 1% of all functional adenomas are sex steroid hypersecreting. Roughly 25% of viralizing adenomas are malignant, and nearly all are feminizing that are malignant. Moving on to our third review slide, team 5. Send it in the chat or unmute. Lorenin, good. Confirmatory testing for aldosterone adenoma. Perfect, salt loading. Treatment. Right, adrenalectomy after the localization, identifying that it's unilateral. And then if it was bilateral hyperplasia, what would be the first step in treatment? Perfect, yeah, spironolactone, potassium for the K wasting, and additionally additional hypertensions, antihypertensive medications to manage. Moving on to tumors of the adrenal medulla, notably pheochromocytoma. So I think we all have probably heard before the 10% rule with pheochromocytomas, and we might have even heard it last week from Dr. Pleats when he was giving his presentation. 10% are bilateral, 10% are malignant, 10% are extra adrenal, and 10% are familial. The type of inherited pheochromocytoma, the type of conditions where pheochromocytoma is part of inherited disease, you'd see with men 2A and 2B, which we talked about last week, von Recklinghausen's NF2, tubular sclerosis, and Sturge-Weber. The classic syndrome of a pheochromocytoma: palpitations, headaches, diaphoresis, vertigo, anxiety, hypertension, tachycardia as a result of catecholamines. So the first step is going to be to medically stabilize. As we had seen in the question, preoperatively, you want to use phenoxybenzamine, but as we saw in the question before, you're going to want to stabilize with something that's not a beta blocker further out from surgery. I believe the answer to the question was to use nitroprusside. Patients can have long-term cardiovascular sequelae from the overabundance of catecholamines in their metabolites, like cardiomyopathy. So this is something that you want to promptly treat. Workup for pheochromocytoma: start with plasma-free metanephrines, which is the best screening test. 24-hour urinary catecholamines and metanephrines is the most specific test. Also could consider clonidine suppression tests. Certain confounders that are listed here in the testing as well. importantly, following up from the aldosteronoma, you never want to do an adrenal vein sampling when you're considering pheochromocytoma, because this can lead to catecholamine release.
Joseph, can I make a quick comment on the previous slide before
Yes,
you move
absolutely.
on? Actually, the previous one, the medications. I think, I am not sure for board purposes or upside purposes, you probably need to know about phenoxybenzamine. Phenoxybenzamine is pretty much not used these days because it's not very commonly to be found on the pharmacies, and plus it's super, super expensive. I'm not sure why. So we use most of the time selective alpha blockers, like for example, doxazosin. It's very, very inexpensive, but we follow the same, methodology. We put them on alpha blockers. We control the blood pressure. If the patient becomes tachycardic, then we start on some beta blocker, and this, is done, 2 weeks before before we proceed with surgery. I am not sure if this slide was talking about that, or you're going to be talking about this later, the preparation.
I think that'll be mentioned a couple slides from now in perioperative management, but
okay, my mistake then. I went too fast.
no,
Sorry.
that's okay. Thanks. So in terms of localization, want to do CT or MRI imaging to localize to a particular side once you have identified biochemical markers indicating a pheochromocytoma. CT characteristics would be, they could be variable size, can be bilateral, as we saw 10%. Usually have increased attenuation greater than 20 Hounsfield units. They could have increased vascularity, and they could have delayed contrast washout. Further imaging you might also consider is an MIBG scan or a 18F-DOPA PET scan as well, could be considered. Kind of in terms of during the procedure, why it's very important to have the proper alpha blockade in place in and around the operation itself. You can kind of see here a kind of pathway how the blood pressure and heart rate responds throughout the procedure at different time points, from tumor mobilization, tumor removal, and the end of surgery, just highlighting how important it is to have the medical management in place while going to the operating room. So that kind of discussed part of this. Post-op hypotension from hypovolemia secondary to chronic catecholamine state is something you need to look out for. And then getting into kind of what Dr. Fernandez had just mentioned, alpha blockade, you're going to want to continue for at least 6 weeks, for up to 6 weeks pre-op. Alpha receptor downregulated secondary to the chronic catecholamine state. This is done to avoid post-op hypotension. And as Dr. Fernandez was saying, you only want to use beta blockers in these patients with persistent hypertension, and only after you initiate that alpha blockade. If you put on a beta blockade without putting on the alpha blockade first, you'd have unopposed alpha stimulation precipitating hypertension, which can lead to a number of cardiovascular events. So continuing with perioperative management, you want minimal tumor manipulation intraoperatively to not precipitate catecholamine release. Ligation of the adrenal veins first to avoid that catecholamine spillage during tumor manipulation. You want aggressive fluid resuscitation after tumor removal due to loss of sympathetic tone. Many patients are going to require pressors post-op for up to 24 to 36 hours. Long-term follow-up for these patients is required. Recurrence rates could be as high as 15%. Mitatyrazine can be given as an adjunct for malignant pheochromocytoma, which inhibits tyrosine hydroxylase, which will decrease the catecholamine synthesis. As we saw, this was the rate limiting step in that production in the adrenal medullary chromatin cells. So this is going to be our final high yield review slide for Elmhurst, if they're logged in. I don't know if I see Elmhurst in chat here. So we'll just go through these ourselves. So rules of 10s for pheochromocytoma, bilateral, malignant, extraadrenal, familial. Oh, there we go. So first step in the management of pheochromocytoma. Great. Yep. Initial workup. Perfect. Follow up after that. Right, this might have been a little bit of a misleading question. Yeah, CT would definitely be right following up in the management to localize and lateralize the pheochromocytoma. I think this was intended to be follow-up testing afterwards, which you want to follow up that the metanephrine levels are going to come down after the procedure. So again, revisiting the slide, we're going to move on to now malignant tumors of the adrenal gland. Adenocortical carcinomas, as well as metastases to the adrenal gland. So adrenal adenocarcinoma is rare, has a 20% 5-year survival rate with resection. More than 50% are functional. CT characteristics you would see with adenocarcinomas, over 90% are going to be 4 centimeters. Which is, again, that's why continuing 4 centimeters is going to be an important number for us for workup of adrenal tumors. They'll be typically irregular, heterogeneous calcifications, usually unilateral and greater than 20 Hounsfield units, and will have delayed venous outflow. For staging, this came up in one of the questions we saw earlier. So T1 is going to be less than 5 centimeters, go to T2 when greater than 5 centimeters, T3 when you have invasion into surrounding tissue, and T4 when you have invasion into surrounding organs, such as the IVC or renal vein. When you're at stage 1, 5-year prognosis, 66 to 82%, stage 2, 58 to 64%, stage 3, 24 to 50%, and stage 4, 0 to 17%. So adrenal adenocarcinomas need to be resected en bloc with negative margins. They can invade into the IVC. Complete resection is the only curative therapy. Could consider palliative debulking to improve symptoms and prolong survival in select cases. In terms of metastases to the adrenal glands, 25% of patients with malignancy have adrenal involvement on autopsy, so it's very common. 50% of the time, metastases to the adrenal gland will be bilateral. Lung, breast, melanoma, kidney, pancreas, GI are the most common primary sites of metastases to the adrenal glands. FNA can be useful to differentiate between metastasis and a primary adrenal mass. When needed to figure out the primary. Isolated adrenal metastases are rare. Often you'll see it in another site as well. Complete resection will improve survival rates. And this came up in a question as well. Mitotane could be used as a chemotherapy option that's particularly good for adrenal metastases. So in terms of approaches for adrenalectomies, you can see the picture here, image on the left. This is indicating port placement for a posterior retroperitoneoscopic adrenalectomy. So in terms of laparoscopic, this approach is going to be for tumors that are less than 6 centimeters, bilateral, and for those that have had a prior history of abdominal surgery. For a lateral transabdominal approach, indicated for patients with a BMI greater than 35 or tumors greater than 6 centimeters. Open adrenalectomy is going to be the right answer when there's any suggestion of malignancy, particularly greater than 8 centimeters. If you have feminization, which talked about is almost always malignant androgen secreting tumors, hypersecretion with multiple steroids, or local or vascular invasion. And the approach for that would be via subcostal incision. So we could take a 10-minute break, or if Hannah wants to get started on the questions earlier,